Thank you, Dr. Lippi, for putting up this very interesting topic, actually, as you said, not touched by many people. And my topic is to discuss about the role of Incident Investigating Committee. Especially in a case of cluster endophthalmitis, this is a very important thing. It's not only that we are going to treat these cases, we have to find out the reason and we have to stop the further calamity also. So the fact-finding committee can be it should be internal as well as external. The internal committee will be usually the hospital infection control committee, and the external committee, of course, the internal committee should inform the governmental authorities, and then they will form the external committees. Usually it will be done by DBCS with a JD, microbiologist, and an ophthalmologist, outside ophthalmologist, and a drug inspector. And also there may be some police inquiry, human rights committees and medias, everybody, of course, they are going to analyze everything. But the internal committee, if the role of the internal committee, it should start immediately, and we have to start with a very open mind, and we have to go for a methodical evaluation to find out the possible cause. If we have done it first properly, the external committee's role will be easier. Not only easier, that it will be also in a better position to defend ourselves. So the committee should first shut down the OT, and also list the possible sources and check for them, and also look and revise your existing protocols, and if there is any violation in that, or if there is any lacuna in the protocol, that has to be revised. And then, of course, trace the other patients. That is also very important. It should be done as soon as you shut down the OT. So to do this, where all the possible infection can come from? Of course, from everything, whatever we use, consumables, or even the personnel, from the environment, from the other things we used in the OT, or even the preoperative preparation area, everywhere we have to be careful. We have to look for everything. So to do this, a proper documentation is very important. It should be like a regular habit for us to document everything. So we'll start with either from the patient list of every theater, especially the theaters in which these things happen, and the other theaters also. So we have to check the patient list, in what order they have been operated, and in which table they have been operated, and that can lead on to a particular either group of personnel or a group of things what we have used it there. And also, as a routine in the theater, we have to what we are going to use in that particular theater. All the consumables, the sterilization has to be checked, both physically as well as the sterilization markers, and they have to be documented on a record. So that again have to be revised, and this same thing will be replicated on the patient's case sheet also. That also has to be matched, and we have to find out. So this is very important, the OT log checking. And all the consumables, generally pre-packed consumables, before releasing them to use, we have to take a random sample from each batch, and we have to check microbiologically. Only if it becomes negative, we are going to release it. Even after releasing, after taking this check, after using, we have to keep all these consumables at least for 48 to 72 hours, we have to keep them. And if there is an immediate cluster infection or something, the samples should be taken from these retained whatever remaining material, we have to again recheck. And not only that, again we have to reopen another unopened thing from the same batch, and again we have to check. And all the shared consumables especially, we have to be very wary of, and we have to check, starting from the topical anti-anesthetic agent we are using. From that we have to check everything. And the protocol logs are very important, because even if the fact-finding committee is going to investigate, we are investigating after an incident happened. So if those things have been documented, only we can investigate and find out something. So as a routine habit, all the sterilization logs have to be like in each cycle, how many bins went in, and these bins went to which theater, and whether the markers are properly changed in color, and the chemical markers, and also biological markers. Of course, we have to do this depends on the load, each theater. Like sometimes some people will do it once in a week, or twice a week, or even frequently we have to do this, and has to be documented, and again we have to revisit and check. And also we have to check our fumigation protocols, and calibrating the instruments, the environmental maintenance, all these things, whether it has been done and really done and documented, and is there any breach in this, we have to recheck. And of course, we have to take culture from every possible material inside and the outside the theater, the pre-op area, starting from the tables and microscope and AC filters, even the water source have to be checked, and these things also we have to recheck again. And whether they are done in the methodical way, and we have to check those logs also. And regarding the medicines, everything, starting from even your antiseptic, what we are using before surgery to prepare, that has to be checked. And I'll tell you in a moment, like, why these things are very important, and their expiry and sample test again we have to do. And I'll share 2 case studies. The first one is a large cluster. It's a infection occurred late, like a month later, a gradual appearing as only inflammation initially and then found out to be infective. It occurred to a private practitioner in Madurai. And once he recognized that, he couldn't find out the proper reason, because the cases were trickling in one by one, cases which have been operated a month ago. But soon he found out a pattern that, one by one these patients are coming. Immediately he sought for institutions' helps, and the institution committees helped him. And then they found out that the offending organism is a rare gram-negative organism, which is actually the source was from the topical anesthetic drop. So the drop, that batch drop, when he used for that 1 week period or 2 weeks period, the patients who were operated at that time, they were coming after 1 month with low-grade endophthalmitis kind of thing, and one by one they were trickling. Unless the surgeon was alert and found out this is a cluster, it could have been easily missed out. And immediately he took steps also to send the patients, refer the patients everywhere, and found out the reason also, and he informed the AIOS committee also, and proper warning also has been given against this particular batch of medicine. That major calamity was avoided because of this methodical approach. The second one, the surgeon used a facility from other hospital because of some need. He couldn't use his own thing, and he went and operated in a new environment where he doesn't have any control. And there, after that, the next day itself, all 4 patients and another surgeon's patients also, they showed signs of inflammation initially. And they even then they recognized it as endophthalmitis and tried to manage in the usual way. The cultures became negative, so the usual routine medications what Dr. Rodney mentioned, they have been given, but then they started showing signs of cloudy cornea, ring infiltrate. They had doubt and referred to our institute. Initially, even we never expected that the offending organism could be acanthamoeba. The accidental, because we did a confocal also, we found out that it is teamed with acanthamoeba, the cornea, then AC tap, vitreous tap, PCR, everything showed acanthamoeba, which is a rare incident, that too as a cluster. So, but here the problem is that it has been recognized after several weeks, and by the time, and that too in a new setup, we couldn't find out the proper reason, what is the source of this infection, still we couldn't find out. So sometimes immediate action and also a proper follow-up only, we can find out the proper source also. So in conclusion, this is a nightmare situation. Of course, it has been reiterated again. We have to be defensive, but we should not deny or ignore or argue with the condition. A calm and methodical approach, face it and explain to the patient and methodically approach. And the internal committee should be strong, internal documentation should be very strong, so that we can find out the reason, so that we can be in a better way prepared to face the external inquiries also. We can avoid very bad situations. And also very important to recall all the patients operated during the time and make sure that whether they are involved, they are affected or not. That is also very important. Thank you.